So, um, I just want to get through a few pressing issues here. So, the part of what happened at ASCO was that three New England Journal papers were simultaneously published about targeted therapy for a couple of the SERDs and another PI3 kinase inhibitor. And so really the question is, what do we do with this information? Right now we only have LSS-trant, and you have to have an ESR1 mutation to get it. And it's being studied in the adjuvant setting and in combination with various agents. And also it's being studied with ESR1 normal patients. We're still learning about the CDK4/6 inhibitors, even though they're approved. And I have stolen the discussant slides because they were fantastic and they're my friends. So the caveat here about ESR1 is that I think it's really just an epiphenomenon. This is from a publication of a paper we wrote about amcinestrant, which is a SERD no longer in development. But we follow the ESR1 status of patients on study. And you can see that the green ribbon diagram blurs into multicolor, meaning patients on an active SERD without ESR1 mutations actually developed ESR1 mutations on treatment. And so did other people. Like they lost one mutation, gained another one. I think it's an epiphenomena, and I'm just not sure it really is what we want to be talking about. But unfortunately, so far, all the SERDs are only approved to be given when the patient has an ESR1 mutation because that's where you see enhanced benefit. But it's not that you don't see benefit. So I think this is an evolving story. So vepdegestrant is perhaps the best tolerated of all of them. It's a PROTAC, and uh, it got one of the New England Journal publications. It is a novel mechanism of action, but it's really similar to a SERD, and it beats fulvestrant in the randomized controlled study, and the ESR1 positive subset does better. And I'm happy to take any questions from anybody at any time. It is very well tolerated. This is kind of a diagram about what we're looking at here, and it's very similar to fulvestrant and other SERDs, but it does degrade. So we have a pathway using the ubiquitin proteasome system that is perhaps a more profound blocker, and lots of opportunities to think about what that means. But it's a very active drug, and we had it in some phase 1/2 studies. So most of us have given the drug and know that it's exceedingly well tolerated. But it's the first PROTAC to be evaluated in phase 3 and developed and was shown to be better than fulvestrant in a meaningful way. And the ESR1 population was the one that benefited the most. So this is the study with over 600 patients randomized straight up and looked at subsets. And you can see that vepdeg did very well here, but not so much better than fulvestrant, which is a good drug. It's just punitive the way it's delivered. And you can see that all the subsets did well, but the ones with the ESR1 mutations and um, earlier lines of therapy and bone-only diseases did better, no surprises. And there were adverse events. There just weren't very many of them, and they weren't very significant. But you can find a little nausea and a few other little things, but mainly very well tolerated. Okay, the next New England Journal publication is the PI3 kinase inhibitor. So Amy Clark gave this discussion about it with the clever pick your partner carefully. So this was Inavo or inavolisib plus palbociclib and fulvestrant. That's too many drugs at once, but should be considered for first line. Yes, the study's positive. Hyperglycemia is a problem, and patients who had prediabetes were excluded. And then she talked about hepatocertib, and I'm not going to get into that today. So, what do we do for patients? You could give endocrine therapy alone, and we can probably pick those patients better, but we generally don't. We give a CDK4/6 inhibitor first line, and then we give a fulvestrant second line. And so the real question is, could we do better in the first line setting for resistant tumors? And we do have a couple of drugs that we can use for PI3 kinase uh, inhibitor mutations. That's capivasertib and alpelisib, and this is the new kid on the block. And they chose to study it in this interesting fashion. So the standard of care, involves different drugs. This is evolving, and when the study was developed, Palbo was first line. Now it's not usually. However, it's perfectly active and not the wrong choice. But it messes up our ability to do serial studies. So this is where just the targets hit these pathways, and you can see that they're all overlapping. So that there is a rationale for triple therapy um, based on this evolution. So this is the trial. They basically were taking the poor prognosis patients and trying to do better for them. And they were randomized to get a novel or not on top of Palbo and fulvestrant. And they did do better. Had a longer duration of benefit and a longer progression-free survival, but they had some side effects that are horrible and then end up on lots of drugs to deal with these side effects. So the survival data was presented. That's the news, and it is a little better. But the flaw is there's zero crossover. So it's very difficult to interpret this. But you can see that it also increases the time to chemotherapy. But there are many patients who would tell you that capecitabine is a lot more pleasant than being on a PI3 kinase inhibitor. So that's the limitation is the control group's not modern. And no one, almost no one crossed over. Um, that's a glitch with the FDA as well. These are set up to be this way to prove the benefit of the drug, but it seems wrong because there are PI3 kinase inhibitors that are FDA approved. So even if they didn't get a Novo, they could have gotten one of the others. Um, and the hyperglycemia is not a trivial issue. So my question is, why wouldn't you do it this way? Why wouldn't you give half the patients a novel up front and give half the patients a CDK4 inhibitor up front, and then when they progress, uh, give them the other? Because, I see it as like you have a stockpile of drugs and uh, you want to dole them out sequentially, and this is um, a way to sort of create a lot of toxicity without maybe creating a long duration of benefit. So this is the way I would have done it. There are a lot of reasons why they didn't do it this way, but I think these are the questions we all have about these trials. Okay, the next one, sort of similar problem, but this gets into the ESR1's story. So, how do you improve things for this group of patients that we all care a lot about, the ER positive metastatic patients? And Serena 6 also was a New England Journal presentation, which involved ctDNA guided switching to camizestrant early as soon as you saw that ESR1 mutation pop up. This could be a new path to regulatory approval, um, and it does establish a role for ctDNA testing, but the clinical utility is really unproven, and we need, I think, a little more information before we adopt this. So this is our example patient who, is a long-term breast cancer survivor, has a late recurrence bone dominant disease. How do we make her life better? And the answer is we gave her letrozole and ribociclib. That's pretty standard of care. So this is kind of the life of a patient with metastatic breast cancer. They don't live long, but they do live long, and you want to have their quality of time uh, to be as high as possible, even though their survival is shortened. So it really seems wrong to make them miserable and not able to ride their bike during therapy and give them a disease that they didn't have previously, diabetes, just to get a modicum of survival benefit. So what should you do? Second line, and this is a list of all the things one could do. And you can only give the elacestrant now if you're ESR1 positive, but hopefully that will change in the future. And certainly when you give a SERD with a novel SERD like imlunestrant, which is also going to get approved, and abemaciclib, you get a huge benefit, but it's still not big enough. You'd really like to be able to overcome resistance and really buy people, many years. So Serena 6 was a study where they uh, started a new therapy when they noticed that you had progressed in ctDNA. They didn't wait until you had progression by CT imaging, by anatomic progression. And this is, so this is the question is, can we look at this and uh, establish the clinical utility of ctDNA. So this is a very high bar to do that. But this is what we're doing. So we switched when we detected that progression. And it did actually improve progression-free survival. It's not surprising. You switch therapies, you gave them something different when you noticed that there was some resistance. So this the testing was done serially, and it's a highly sensitive assay, uh, and camizestrant is active, um, and did drop the ctDNA, the liquid biomarker. But the question is, what else really does this add meaning? So the patients did fine in the control arm. What if you crossed over later? Would you really get the same effect? And will this really benefit people in terms of clinical utility? So, you can have a biomarker and it can be clinically valid, but it might not really be clinically useful. And so this is one of the things that we struggle with, and this is the bar we're trying to get FES over. And I suspect it will, and I suspect it will beat ESR1, but that's not the topic of this talk. So, um, the other issue is what about if you just look at how they did overall, like later? Like, if you look at their progression-free survival on their next line of therapy. And what you can see is that you still seem to benefit, but maybe all that happened is that when you switched traditionally, you just brought them right up to where they'd be with the early switch. So there was no crossover. It's another problem. And there's a real imbalance in what treatments were available between the arms. So I think if we were to cross over, I think that would answer the question, and that was not done. Um, so we're underwhelmed here. And there was more chemotherapy in the group that switched over. Maybe they could have been tested for a PI3 kinase mutation and switched to something different. There are a lot of things, good things one could have done at that point. So should we um, should we move forward without any clinical utility proven? And the ctDNA testing is a huge burden. And it may improve overall survival, but that isn't really proven by this study. So you did a ton of tests. You have a very low yield, and then you got these patients who agreed to be randomized. So is this how we're going to do things in the future? This is a lot of work. There's a lot of cost, and I think it's hard on patients. Um, we have a tumor marker, and there's the standard blood marker that we is clinically available, and these are anxiety provoking for patients. And so now we're going to sort of have just more anxiety by knowing that that blood test is positive. But I think this is a cool study to talk about. I don't think it's a game changer yet. And I think it's just too early for us to assess the overall survival and the progression-free survival on the second and third lines of therapy. Um, but it is exciting to think that we can delay chemotherapy in patients. It's exciting to see the activity of the SERD, and we have to assess all these other costs. So Angie's, Michelle's conclusion was don't recommend doing this yet. Just keep doing what we're doing, but this is interesting, and I feel the same way. Okay, so the other study I wanted to get to, oh, I'm like too fast. I have to slow down. Um, is this study I think actually is practice changing and it's affirming of many things. So I'm really glad that this was presented at ASCO. Um, y- we have a real problem with abemaciclib. It's a very active drug, but it's extremely poorly tolerated. So they looked at a dose escalation strategy and were able to reduce treatment discontinuation and allow most people to reach the target dose. And this could reduce toxicity, really. So the background, CDK4/6 inhibitors are standard of care in the metastatic setting, but in the adjuvant setting, really, abemaciclib is the one that's FDA approved and it has the highest magnitude of benefit. Um, it is effective, but there were too many early deaths in the adjuvant study monarchy. It's very toxic, and there are patients who are hospitalized. There are patients who just refuse to continue, and there are patients who would rather be on a different drug. But this drug has the greatest magnitude of benefit in this setting by the way it was given. This is a 2-year treatment. Palbo was a 1-year treatment. Ribo is a 3-year treatment. This is a real dose, high full dose that we use in the metastatic setting, and Ribo is a lesser dose than we use in the metastatic setting. That probably doesn't matter, but it's a 3-year commitment. So this was a way to get around these toxicities and make this a little better tolerated. So this is what they did is they offered patients, this is in the adjuvant setting, not the metastatic, although one could argue that you could give it in the metastatic setting. This study is only about the adjuvant setting. So they screened 90 patients. They gave them 50 milligrams of abemaciclib for 14 days. And then they pushed it up to 100 milligrams for 14 days. And then at day 28, arrived at the 150 milligram dose. That was the plan. It's not exactly how it went, but that's so it's a ramp up. It doesn't take forever to get there. And notice that you're on BID dosing the entire time. So you're on drug. We know that 50 is actually active. So they took patients who had stage 2 and 3 cancer who were eligible for adjuvant abemaciclib and enrolled a variety of patients from the Dana-Farber Cancer Center. Uh, this is looking at just the 12-week point of are they really on drug and are they tolerating it okay? And this is the interesting part. So if you look at when they got to the green, 150 milligrams, when they got to the big dose, you can see that some people didn't get there until, way after, or not at all, the planned 14-day mark. But they actually reached target dose in these patients and kept them on it better than when they did the monarchy study. Sorry about the dog here. Um, so so this is actually kind of impressive. Um, but there still is toxicity, the same toxicity that we're all very familiar with, the diarrhea and the neutropenia and the fatigue. But they were able to get more people on study. I think this part really shows you that these patients are still pretty miserable, with fatigue and GI side effects. However, the trade study met its primary endpoint and showed that an initial dose escalation strategy allowed a greater number of patients to reach and maintain the big dose. And that's greater than was observed in the trial when you started at the big dose. So I think this is very appealing. You could suggest that maybe you could improve on this problem here by not going up to cycle 3. Meaning stay at the 100 dose. Because I still think these are pretty miserable patients, but they're adherent and they're able to tolerate it. So early discontinuation was infrequent, and uh, it's been established that this can be maintained. This is okay, that patients who require reductions do okay. So when you look back here at the patients who in the brown down there on the far right, some of the patients just stayed on the lower dose, and I think that's a very reasonable thing to do. Uh, but this may be a way to improve adherence to abemaciclib and just make people's lives a little better. So they've got more work to do, but I think this is a strong study and a bold conclusion that this is a way to get people to tolerate the drug, and I think most of us are going to do this in the metastatic setting, even though that's not what we're supposed to take away from this. But you really don't want people in the hospital. You don't want people miserable. You want people to be able to take their drugs and feel okay and get the benefit. This is a very active drug. It's just kind of a gnarly GI toxicity. And that is well, okay. I told Tasha I would keep it to under a half hour. But I fear I've gone too fast. However, we have time for some fun discussion. Gina, help me.
Yeah, I actually had a question on the trade protocol. Do you happen to know, Dr. Linden, if they reported on the average time that it took people to get to the full dose? I think now that we have been doing a lot of these ramp ups in clinic, I think that's where we're really struggling with as a pharmacy group as we do the follow-ups to be like, you've
Mhm.
kind of hit the median duration of this titration, and this is like where we call it quits, or we give them a little bit more time to get them to the next dose.
Yeah, I mean, I think that's the $64,000 question, Gina. One of my friends in practice told me they just give 50. I mean, it, it was very disturbing to me the deaths in the adjuvant setting. That's not acceptable.
Mhm.
Um, so I really think what we should do is kind of let patients tell us what's tolerable enough for them and let them stay at 50 or 100 and not push to get to 150. That's my personal belief. I feel like 150 is just too hard, and that's why I sort of wanted us to look at yes, they got the patients to do it at the Dana-Farber, highly motivated patients who wanted to be on a study, but they were miserable. You have to spend 2 years with being miserable with GI side effects. I don't actually think that's good for you. I
Mhm.
find myself worrying about, the damage to your gut, as well as just the fact that, you're less likely to go out for a walk if you think that, you're about to have a GI explosion. So I think we want to just go gently with these people. And it's better to get some in them than to not have them take the drug at all.
Yeah, I think that's helpful to know kind of where we want to stop because I think we sometimes do have people that are at the 50s for like 1, 2 months, and we're like, do we pull the trigger and see if they can go up, or do we just call it a day? So that's helpful. Thank you.
Yeah. No, the thing that I feel badly about with the other study, the camizestrant study, is it's, sort of an advertisement for doing liquid assays. It's what patients are asking us about. But I really think that's not the right answer, because, most of these patients have very indolent disease, and you're basically just calling it early, and you're not necessarily making any difference. And the truth is that if you keep watching these people and don't switch therapy, that ESR1 mutation might go away. And you can still get a SERD because you've got proof that they had one once. That's the big crazy part of this whole thing. All you have to do is show that you've had one ESR1 mutation sometime, and then you qualify for the drug. So, but it's interesting. I think, we're still trying to figure out how to really uh, do the right thing for patients with these liquid assays and not just kind of chase our tail. But no, that's a tough thing. But it was an exciting meeting, and I think these are, good discussions, and I think we will probably have more SERDs as time goes on. I hope we'll have a clinical trial with vepdeg with Megan in the locally uh, recurrent space, and I hope we um, can continue to study all of these. So right now we have camizestrant in the adjuvant setting. That study is ongoing but is closed to accrual. But we're about to open Elegant, which will look at elacestrant in that space and will not have all those eye exams because it doesn't have that toxicity. So that's nice. And I think, it was interesting. I think one of the ideas is potentially that elacestrant does have some GI toxicity, which vepdegestrant doesn't. Not sure that's totally true. But at least the vepdeg people were willing to go up against fulvestrant and show the utility. Other things we can talk about while we wait for Tasha here.
I'm here.
Excellent. Sorry, I talked too fast. I tried.
Thanks, Hannah. Yeah, thanks a lot for ending early because I really do love speaking in front of groups, as you know.
Yeah.
I will share my screen here. Hannah has asked me to really focus in on the Bernard Fisher symposium that I spoke at and summarize some of the ctDNA data that was the most prominent at the meeting that was presented in the breast context for at ASCO. So let me share here. Um, And for those of you who attended the symposium, the first part of this will sound eerily familiar because I'll probably just summarize, I will be summarizing my own presentation. So, um,
Repetition is the essence of learning.
that's right. It's also isn't it the hobgoblin of little minds? All right. Can everyone see this?
Yeah.
Great. So I don't have any financial interests or relevant financial interests to disclose. So I'll be talking about 4 studies today. All of these were presented at the Bernard Fisher Breast Cancer Symposium at ASCO earlier in June. The first was a study that I am co-PI with Heather Parsons on, which is a TBCRC study, TBCRC 040, which closed in 2018, but was presented at the recent ASCO meeting called Predict Breast. Then Pedram Razavi presented the DARE trial. There is ctDNA to monitor for response to therapy in MBC and ctDNA to detect
Recording in progress.
detect HRD in. I now have a very strange echo. Oh, no, I don't anymore. Okay. To detect HRD in metastatic triple negative breast cancer and to predict response to PARP inhibitors. And just to give a very tiny introduction to what is ctDNA, you probably all are quite familiar with it at this point. It is, in its most basic sense, tumor-derived DNA in the bloodstream. We all have DNA free floating in our bloodstreams from cell turnover. So some of it just represents our own healthy cells that are turning over. But some of it, if you have a malignancy, can represent cell turnover from cancer. And we are able to detect that through the mutations that cancer develops in order to grow and survive. It is very small, so it's short strands, 200 to around 200 BPS, which corresponds to the length of DNA that wraps around a nucleosome with its linker. It has a very short half-life, so it can be quite a dynamic measurement. And it really varies very widely, and which is one of the challenges to figuring out the clinical utility of ctDNA because it varies in terms of tumor type, tumor growth, amount of necrosis, and the location of the actual tumor. It has a lot of potential applications. Some of these are being realized very actively currently in the breast cancer setting, as Hannah mentioned, in terms of ESR1 mutations and eligibility for elacestrant. PIK3CA can be monitored through or can be tested with ctDNA with a companion diagnostic. And so, but in terms of all of the kind of array of potential applications for ctDNA, it's important to keep in mind that ctDNA is not necessarily, while it is what I mentioned, it is, most basically cell-free DNA that's tumor-derived that is found in our plasma. Detecting it isn't just any one thing. So essentially the thing to keep in mind, or the principle to keep in mind, is that we can detect common mutations if there is a high tumor burden and a high volume of DNA floating around in the blood. You can look for sort of common mutations that we might find in breast or another tumor type. And so you can look sort of broadly but shallowly. Or if you know what you're looking for, if you know exactly where the needle is located in that haystack, you can look quite deeply, but you can only look for specific things. And so that really changes how the kind of constellation of things that you can do in different settings for ctDNA. So this is an illustration here. If you can imagine here, I don't know if you can see my cursor, but we can sort of arbitrarily define a limit of detection for ctDNA. Obviously, that's going to change according to what I just mentioned. So your limit of detection is going to be quite a bit higher if you're looking, or lower if you're looking for very specific mutations. You can detect it down to 1 to 3 parts per million, so extremely low limit of detection, meaning extremely sensitive, or higher if you're looking, like I said, more broadly for kind of general mutations. But if you can just imagine this limit of detection as kind of a cartoon drawing, you can imagine that with screening, there's no ctDNA initially with a cancer-free situation. As you develop an early stage cancer, those ctDNA levels may rise. One application is for screening currently that is being offered by Grail and a couple of other companies, but I would say that it is definitely not ready for prime time. But once you get to have a certain uh, burden of disease, which you may do if you're needing neoadjuvant therapy, usually those are fairly bulky tumors. And so there are studies ongoing, and we'll talk about one of them in this presentation, looking at monitoring neoadjuvant therapy, response to neoadjuvant therapy using ctDNA. So you have a high burden of disease, you have good detection of ctDNA. Does the response to therapy, can it be reflected in the ctDNA levels, and can that be predictive of various outcomes? In the acute adjuvant setting, you can test for, is there tumor still present? Presumably that ctDNA level has gone down because you've reduced the burden of disease. And then in the less acute adjuvant setting, in terms of monitoring for recurrence, I think a lot of us in practice are being asked about Signatera. So that is a form of ctDNA assay, and it is a tumor informed. In other words, you're looking for that specific needle in that haystack. You're looking deeply and specifically for the specific mutations that that person's tumor had. So that is an opportunity to detect relapse. If the ctDNA starts to rise, if those cells that are below the limit of detection cells start to grow and divide, start to shed ctDNA into the blood, they become more detectable. So a lot of research is going into detecting minimal residual disease, or MRD, through Signatera and other assays like it. And so we'll talk a little bit about that during this presentation as well. And then after a metastatic recurrence, oftentimes the burden of disease is quite high. And so we could characterize some of those mutations and do treatment selection based on that. So in that case, it's not a level of ctDNA, but it's specific mutations that we're searching for example, ESR1. Whether that's clinically actually useful or not remains, as Hannah was talking about, remains a question, but certainly it is possible to do. You can detect those mutations and possibly detect them coming or going. So you're looking at possible treatment selection based on the pathways that are represented by the mutations in the tumor, and those mutations are reflected in the blood. We can prognosticate, but we can also potentially detect resistance. And so those are kind of the whole array of potential applications, and they really depend on what kind of question you're asking to determine what kind of test you may need. You may need an ultra sensitive test looking for very low levels, just looking for the presence or absence of tumor because you're looking for recurrence versus not, or you're actually looking to characterize the actual mutations that are present because you want to use those to select a treatment or to change treatment in the face of resistance. So that's sort of the very brief overview of what we're looking at. And then the studies that were presented in this symposium represent a number of different aspects of those applications. So the first one is the one that I and Heather Parsons, along with our mentor, Ben Park, who is currently the head of Vanderbilt Cancer Center, Heather Parsons was responsible, Heather and Ben were responsible for writing this trial, and then we implemented it and are finally reporting our results out. So this was circulating ctDNA after neoadjuvant therapy for breast cancer as an independent prognostic marker for recurrence. And so this is the TBCRC 040 trial. And Ben very cleverly put together a lovely acronym that spells PREDICT DNA. So it is the PREDICT DNA trial, pathologic response evaluation and detection in circulating tumor DNA. So in this trial, we studied patients with stage 2 and 3 HER2 positive or triple negative breast cancer who were receiving neoadjuvant therapy prior to surgery. As you are aware, pathologic complete response after neoadjuvant therapy is associated with better outcomes, improved survival. Patients who do have residual disease on pathology, who don't achieve PCR, often receive adjuvant therapies like capecitabine, but also many patients who don't receive those therapies do well. And then minimal disease detection, we thought, as measured by circulating ctDNA, could potentially improve the identification of patients at risk for recurrence. So our hypothesis was that ctDNA may predict for PCR in patients with early stage triple negative or HER2 positive breast cancer. And this is reflected in our primary aim, which was for both the triple negative and HER2 populations, which was to determine the negative predictive value of ctDNA for PCR following neoadjuvant therapy. And so that's sometimes a little bit hard to get your head around, but essentially it means does the disappearance of ctDNA after neoadjuvant therapy predict for the absence of residual disease? So in other words, if ctDNA disappears, do you have a PCR? And then our secondary aim was 5-year invasive disease-free survival. So again, more plainly spoken, can we, with using ctDNA, identify patients with triple negative disease who are at risk for recurrence? This was our study schema. We enrolled stage 2 and 3 triple negative and HER2 positive breast cancer patients who were planned to get standard neoadjuvant therapy, although we did actually allow study trial participants as well, but they did have to be receiving cytotoxic and an anthracycline containing regimen. We got tissue at diagnosis and then at surgery, if it was available, if they did not achieve PCR. And we got we did a post-neoadjuvant surgery time point, and then following surgery, we tried to get blood at 6-month and then 1-year intervals. The critical time point that our primary and secondary aims depend on is this one in the blue box, our post-neoadjuvant pre-surgical time point. So patients that were evaluated for both the primary and secondary endpoints needed to have tissue, and then they needed to have that blood draw at this post-neoadjuvant time point to see if we could predict for PCR. Our statistical plan is summarized here. Essentially, it's just a very standard analysis using sensitivity specificity. And we defined our positive study to be a negative predictive value of 90%. So our methods, we used Personalis, which was a whole genome tumor-informed assay, so very similar to Signatera. The assay that we're using with Personalis is quite a bit more sensitive. They call it an ultra-sensitive assay, but what they mean by that is that it is the limit of detection is down to 1 to 3 parts per million. Signatera also has a similar assay available, but it is non-commercial. So the Signatera assay itself is less sensitive. So we used Personalis. And this is our consort or remark diagram. The demographics show that the triple negative and HER2 positive breast cancer patients were evenly divided, and they were also divided pretty evenly between we had 130 post-neoadjuvant patients for evaluation, of which 68 were triple negative. And they were also fairly evenly divided between stage 2 and 3. So ultimately, we had, looking at our results, we had 165 out of 178 patients who had detectable ctDNA at baseline before neoadjuvant therapy. 91 of those 221 patients had PCR, and then 100 of 130 patients with a post-neoadjuvant blood draw. Remember, that's that critical blood draw of evaluable patients for our primary and secondary aims, had undetectable ctDNA at that time point. And 60 of those had a PCR at surgery for a negative predictive value of 60%. So our study did not meet the primary endpoint of an NPV of 90%. However, we felt we had some more exciting results than that when we looked at our pre-planned secondary aim, which was invasive disease-free survival in patients with triple negative disease. And again, remember, this is only powered for patients with triple negative disease because HER2 patients do so well, so we were expecting to see quite a low event rate in that population. So we stratified our study for patients where we expected to see more events. In this plot, we see all the patients stratified by PCR versus non-PCR, regardless of whether ctDNA was available for them. So these are patients who may or may not have been able to get ctDNA at that critical time point. And we did this to verify that our results were not skewed by anything contributing to ctDNA detection. And here you see a hazard ratio of around 2, but it is not statistically significant. And then in the next diagram, you see the same analysis, but this is excluding patients that we did not have blood samples for. So these were all the patients where we had tissue, surgical reports, and a blood draw at that post-neoadjuvant time point. And the curves are very similar, with p-values kind of trending toward, but not reaching significance. So our data indicates that in this population, PCR was kind of a decent, but not a perfect measure of risk stratification. And then we looked at triple negative patients with undetectable ctDNA after neoadjuvant therapy. And these are patients who had no, like I said, no ctDNA detected after neoadjuvant therapy. And you can see here that they were nearly 10 times less likely to experience recurrence, regardless of PCR status. So if you look at this comparison, ctDNA and PCR results here in the yellow line, you can see, realizing that I have some somewhat out-of-date slides here, but in the yellow line, you can see the ctDNA and non-PCR and ctDNA patients who were ctDNA negative who did not have PCR compared with the gray line, ctDNA negative. So these are undetectable ctDNA who had PCR. They had very similar excellent outcomes. So those curves are almost overlapping. And then you see the ctDNA positive patients in the blue line and patients who did not achieve PCR. Those patients did poorly. And the reason we don't have a fourth line for ctDNA positive and PCR positive patients was that none of our patients who achieved PCR had circulating tumor DNA discovered. So essentially, we found that ctDNA was a stronger predictor than PCR for recurrence in our population. We then did pre-planned analyses with post-surgical ctDNA sampling over time. Sorry, these are not pre-planned, exploratory analyses with post-surgical ctDNA sampling over time. The patients identified here in red who stayed persistently, so just to be clear, these are patients where, regardless of what their these are patients where we monitored after surgery. So this is not that critical time point. Patients identified here in red who stayed persistently positive for ctDNA. Those patients had very poor outcomes. Patients who converted in the middle here in gray from negative to positive were also at high risk of recurrence, but the patients who stayed persistently negative had excellent outcomes. And again, we only had one person relapse in this group. And again, this is independent of PCR status. So in conclusion, ctDNA was not a sensitive predictor for PCR in stage 2 or 3 triple negative disease and HER2 positive breast cancer. In the triple negative cohort, preoperative ctDNA was a strong predictor of recurrence with a hazard ratio of 9.6 compared to a statistically not very significant hazard ratio of 2 to 3 for PCR in our population. And it was a significantly stronger predictor than PCR. Serial post-surgical ctDNA preliminary analyses indicated that triple-negative breast cancer patients who had minimal residual disease detected by ctDNA were over 85%, 85 times more likely, not 85%, 85 times more likely to experience recurrence. And so if patients had any detectable ctDNA after surgery, they were extremely high risk. And then ctDNA detection in patients with triple negative breast cancer after completion of neoadjuvant therapy, we think has a very high potential to become a prognostic marker to guide clinical decision making and stratification for clinical trials. So that's that trial. Then very briefly, I want to go over the last three, the other three trials. I did steal their slides, but I think that they probably are better representative of anything that I could provide. So this was so going back to the diagram where we looked at the applications. This would be an application of detecting minimal residual disease during adjuvant treatment. So these are patients they were monitoring circulating tumor DNA for estrogen receptor positive patients, high risk patients during adjuvant endocrine therapy. And so these folks, they're trying to answer the questions. There's a number of questions that are still unanswered in terms of how we monitor during adjuvant therapy. But I think most people agree that ctDNA holds a lot of potential for detecting relapse before clinically apparent recurrence. And Signatera has been shown to detect molecular recurrence around 5 to 6 months with a 5 to 6 month lead time over clinically or radiologically apparent recurrence. And so the opportunity, I think most people would agree, is that early intervention may delay or mitigate that recurrence. But in terms of the questions that still remain in play, the ctDNA positivity rates in the ER positive population, ER positive disease tends to be more indolent with less turnover. And so it's less clear that that would provide as sensitive a biomarker. How often when we do detect it, do we actually find metastatic disease? So we detect the ctDNA and then scan. How often do we actually already find metastatic disease present? What are the characteristics of ctDNA dynamics in early stage disease? And so in other words, do they respond to endocrine therapy? What does the trajectory of ctDNA look like, even if we can detect it? And then what is the impact of early intervention? So this study attempted to answer three of these questions. It was a non-interventional trial, so it did not attempt to answer the fourth one. They looked at a high-risk group. So through our various risk models that we are familiar with, such as PREDICT, they looked for greater than 15% recurrence risk. People had to have 4 positive axillary lymph nodes and a fairly large tumor. And then they tested those patients for ctDNA. If they were positive, they underwent imaging. And if imaging was negative, if imaging is positive, then obviously they enter a more standard metastatic pathway. If imaging was negative, they were randomized to continue adjuvant therapy or switch to fulvestrant and palbo. So I mentioned that this was a non-interventional trial. It is an interventional trial, but these are just the preliminary analyses. And so we don't have the results yet of the actual intervention. So this is an interim analysis looking at negative predictive value for recurrence-free survival and molecular recurrence. And there are a number of slides, but I think this is probably the most relevant one. So far, they have 1 of 9 patients who have cleared ctDNA. And 1 of 9 patients with ctDNA clearance or decrease at 3 months had clinical relapse, but 6 of 10 with increasing ctDNA had clinical relapse. So in other words, patients who had increasing ctDNA trends were more likely to experience relapse if they had ctDNA detected. So This trial shows that 12% of patients were ctDNA positive during surveillance. 73 of those 12% were imaging negative for metastatic disease. 86% of patients with a positive test had a positive test after an initial negative test. So in other words, went from having a negative test, they turned positive, and uh, and then sustained negativity of ctDNA was associated with good recurrence-free survival, and sort of interim preliminary data seems to show that in very, very small numbers, seems to show that ctDNA detection without radiographic recurrence is predictive of that radiographic recurrence later on down the line. This next trial was Pedro Razavi's trial, circulating ctDNA as a predictor of treatment response. So in that line of applications, we're looking at a metastatic population and determining how they are responding to treatment. As you know, currently, the way that we make our decisions is based on radiographic recurrence. And so this is an attempt to at least combine or use ctDNA, and you'll see here in a moment, in some cases solely as the sole discriminator for, or the sole uh, tool for decision making in treatment switch or continuation. And so the aim here was to determine the relationship between early on treatment ctDNA dynamics and real world treatment outcomes. The Pedro Razavi is at MSCKK, so he's at Memorial Sloan Kettering. They do very routine sort of at presentation, patients get their tumor sequenced, and so this was a trial that they were able to implement quite handily. So they used a database to link their claims data to evaluate the association between ctDNA dynamics and the time to next treatment. So these are all folks who were adults diagnosed with metastatic breast cancer, and they used Signatera as their platform to test for recurrence. So the way that this worked was that you had pre-treatment, you could be tested for ctDNA up to 4 weeks prior to treatment initiation, and then you had an on-treatment ctDNA test. And then they classified these dynamics in terms of favorable dynamics versus unfavorable. So if you cleared your ctDNA, went from positive to negative, or you had a decrease in MTM per ml, so that is mean tumor molecules per ml. So that's a different way to quantify ctDNA. Or if you just were negative and remained negative, that's considered to be favorable dynamics. If you went from negative to positive, or you had an increase in MTM per ml, those were considered to be unfavorable dynamics. And so they stratified their patients for unfavorable versus favorable, and then tried to see whether that was predictive of time to next treatment. And they found that patients with favorable ctDNA dynamics had longer time to next treatment. And this remained true across tumor subtypes, and it also remained true across treatment types. And I don't have the slides here showing you those data, but they do have data showing pretty consistently that regardless if you had favorable ctDNA dynamics, you remained on the same treatment for longer across all tumor types and across all treatments. And then he presented a couple of case studies. And while I was sitting there, I was thinking, why are we looking at case studies at ASCO? But but then when he explained what had happened, I thought that this was a pretty bold approach. So I think it's worth presenting here because it represents kind of what we could potentially be looking at in the future. I don't think many of, at least I shouldn't speak for anybody else, but I wouldn't have had the courage to proceed in this manner, but they did, and it really panned out for them. So this was a person who was diagnosed with a high-risk triple-negative breast cancer in 2020. In 2023, she had a recurrence in her CNS. She continued to be monitored, had a recurrence in her liver in 2023, was treated systemically with TDXD. So this was a biopsy-proven hepatic metastasis. She was found, if you see here in this October 2023, if you look at the comparison between August and October, I think most of us would say that that is progression, and we would say that's a failure of Enhertu. But if you look at her tumor ctDNA dynamics, her MTM per ml volume went down significantly and remained flat. And so this very bold researcher continued to treat with TDXD, thinking that this was actually a tumor flare. And then the tumor actually, with time, disappeared. So that is that earned him a Vogel question. So that was a pretty bold but very interesting approach that was ctDNA guided. So the last one I will go over very, very quickly because I think it's sort of the least clinically exciting. But this was an assessment of ctDNA homologous recombination deficiency in triple negative breast cancer, looking at whether detection of HRD could be used to provide a PARP inhibitor and gain benefit from a PARP inhibitor. So the background slide, there's a lot of background that the authors provide, but I think that this is really sums up their background. So genomic instability score is an FDA approved metric looking at HRD. So the SWOG 1416 trial showed that GIS of over 42 is a robust and independent predictor of response to volaparib in triple negative breast cancer. And so the researchers thought, if that's true, then if we can detect these somatic mutations in triple negative breast cancer, so if we can detect HRD in triple negative breast cancer via circulating tumor DNA, can we also predict benefit to volaparib? And essentially the answer in their case was no. It was not prognostic either for progression-free survival or benefit from volaparib. And so I think they basically stated that they had a little more work to do to try to think about where they're going to take that from here. So I have 3 minutes remaining. Happy to, I'll stop share. Happy to chat. All right.
Nice job, Tasha.
Thanks, everybody.
You want to predict the future for us for liquid assays?
I'm sorry.
You want to predict the future for us with liquid assays?
I mean, I'm a little biased, right? But I actually do think that that in the next, I know everybody always says 10 years, but I think in the next 10 years or so, we will probably see some pretty exciting interventional trials where we're using liquid assays to guide treatment. But I think for me anyway, the most exciting application is MRD and interventions when we have molecular but non-radiographic detection, because I think that that's, if you have very low volume disease, we know that we can cure low volume disease. We do it all the time in the adjuvant setting. So if we have a way of detecting low volume disease in the sort of surveillance further out setting, then I think we have the opportunity to intervene and prevent metastatic breast cancer. So I think that to me is kind of the winning the lottery. And I really hope that we can see that. I think we're moving toward it.
Yeah, I mean, I guess your PREDICT trial showing, that post-surgical after neoadjuvant chemo can help predict, certainly from a radiation oncologist perspective, to help us understand like who of these patients are really higher risk, like worthy of more treatment now rather than omitting. I wonder, it'll be interesting if B51 collected blood that's analyzable at that time point to kind of see how if it may have impacted outcomes on that trial. But
How it lines up. Yeah. I think most studies at this point are collecting these correlatives pretty reliably, but it always takes longer to report out on those because those are not usually the primary endpoints. But I think that the thing that's interesting about ctDNA and PCR is that PCR is a surrogate endpoint, and ctDNA is, I think, more like a CT scan. I mean, it's like direct measure of actual disease rather than being, a correlated surrogate endpoint. So,
yeah, cool.
So if we had used your data, you could have reduced treatment in patients as well as increased it, right?
correct, correct. If people are ctDNA negative, even if they had residual disease at surgery, they did incredibly well. I mean, it makes sense, sort of like if you still have residual disease, it doesn't mean, you still have removed all of that disease. And so,
That was actually one thing I wanted to point out, was, on B51, I don't know if you separated PCR into breast PCR versus nodal PCR, but obviously B51 had all nodal PCR, and then it was 80% breast PCR, but 20% no breast PCR. And like on that planned subset, there was really no difference in outcomes between people with a breast PCR or residual in the breast. So, you're starting to get split hairs in the data that you have, but if you're looking at any like all PCR, you may find that if
actually,
yeah.
that's a really good thought. I mean,
Yeah.
the PCRs
Yeah.
the non-PCR data is, like you say, you sort of start to get pretty small numbers, but I think that's actually a really good analysis to look at.
Great job. Thanks.
Well, thanks, everybody. Thanks for putting up with my stumbling through.
Hey, thanks for doing this. Appreciate everybody.